Good afternoon, everybody. Please do take your seats. I'm keen for us to start, well, inevitably not quite on time, but as close to on time as possible. So I'll just give it a few minutes for people who are coming in now, but please come in as swiftly as you can and take a seat. So I'm Stephen Vogel from the Health Sciences University and had the, well, hopefully so far, the pleasure of being on the organising committee for BritSpine. And so thank you all for your attendance. And Martin said just make the introduction brief, so I will. I'm delighted that Professor Martin Underwood has agreed to speak on the topic of the good, the bad and the ugly of clinical back pain guidelines. I was hoping for the spaghetti western music, but neither he nor I have sorted that out. So Martin has got a vast experience in clinical guidelines, having worked on multiple guidelines, chaired guidelines for NICE, both in the realm of back pain and other areas, and in quality assurance of NICE, and more recently, although I don't think it's got a lot of press in the UK, but the World Health Organization guidelines, which Martin was a lead chair. And of course, I'm really interested in it, having been involved in a couple of guidelines myself. And so, although I'm nervous about what Martin's going to say, because it might be Professor Underwhelmed rather than Underwood in terms of guidelines, I'm delighted that Martin's agreed to speak, and I'm sure you're going to enjoy his presentation.
Thank you, Steve. So these are my declarations. But actually, what's more important than my declarations is my perspective. This is where I am. I'm a retired GP. I'm interested in research into musculoskeletal disorders. But I've also got an interest in guideline development. As Steve says, I've chaired a couple of guideline groups for NICE. I chaired the 2009 back pains guidelines, and I enjoyed those so much, I went back and I did headache guidelines. And the rationale I made to myself is, well, I know quite a lot about back pain, and actually the head is just the top of the spine, so it can't be that different. And they agreed, but I knew nothing about headaches, and I persuaded NICE that it was acceptable to have somebody who didn't know anything about the subject chairing a set of NICE guidelines. And actually, over the years, NICE policy has changed along with this, and these days they realise how important the chair is, and the chair's perspective can drive many aspects of guideline decisions. So now they're very clear that nobody who knows anything about the subject is allowed to chair a guideline development committee, and you get appointed on your chairing skills, not on your clinical knowledge. I also, until the programme was disbanded for money-saving reasons, chaired the NICE Accreditation Advisory Committee. And the job of this committee was to assess the quality of guideline developers' guideline development processes. So this is really getting into the core of how this stuff is done. And this was interesting, because amongst other things, they had to assess the quality of NICE guidance, whether NICE guidance was being produced to an adequate standard. But interestingly, one of the things I was given really early on to assess was we had to decide whether the British National Formulae, the BNF, was up to scratch. And this is like being given the Bible and be asked to judge on its literal truth. And in truth, the BNF failed. It didn't meet the standard. It wasn't literal truth. It is a lot improved now. So in terms of this presentation, the scope, it's about guidelines. I'm going to focus on those largely got some relevance to a UK context. And on my personal experience of this, and it's about primary care. There are loads of back pain guidelines out there. I'm not going to tell you about all of them. There are systematic reviews. There are systematic review of the systematic reviews. And I'm just going to focus on treatment of non-specific low back pain. There are other cans of worms that I'm not planning to open today. So I'd like to just reflect at the beginning to go back early in my life about what life was like before guidelines, back in the beginning. There was no form, there was no void. And this is my first real experience of back pain. This is my mother, a healthy woman in her mid-40s who loves her garden. And she got acute severe back pain and got it in the early 70s and was advised for strict bed rest by the GP for several weeks, which was a great formative experience for me because my father had no idea how to run a household. So I ended up running the household for a period of weeks. The next episode that influenced me about my views on back pain. Now, Steve is here. Steve gave me the brief of a spaghetti western. And this is a rather more niche genre of films. This is a spaghetti zombie movie. And the relevance of this spaghetti zombie movie is that it was partially filmed at this building, which is Barnes Hospital in Cheadle, a few miles down the road from here. And it's a rehabilitation hospital where I worked at one time. And I had some responsibility for rehabilitation after neurosurgery, where we managed people where things had gone badly wrong after spinal surgery. And really, it was just awful seeing some of these people. And it really put me off the idea that anyone should ever let anybody operate upon their back. But if you wind back maybe 30 years ago, this is where I used to work as a GP, 10 or 11 stops down the tram line from here, where I knew nothing about how to treat back pain. It was a complete mystery to me, and I could have really done with some guidance. And thinking back to when my mother was ill, this is the source document they went to from the Consumers Association to get advice on how to do back pain. If you just spend a second or two reading what this advice, I think it's dated slightly. It doesn't really fit with what we'd expect to see today. I love the idea that maybe someone else other than the housewife should make the bed. But the advice on walking tall really fits. It's reasonable advice. For the younger people in the audience, that's what a piece of coal looks like. But moving on to stuff that's a little bit more scientifically based. Here is your first Cochrane review of back pain. In 1979, work loss and disability due to back pain was seen as a really big problem. And the government wanted to set up a committee to decide whether there should be improved back pain services. And this was under the chairmanship of one Archie Cochrane. How good is that? You actually get the man himself advising the government on development of services. And like almost every other Cochrane review in this area since, the conclusions were we don't know enough about how to make rational changes to services. There's no point in putting any new services in because we need more research to underpin all of this. And the focus here is on acute back pain and getting people back to work. Because this is still in the days when we thought managing acute back pain was important. The next big step forward around guidelines was the AHCPR guidelines from the USA. The first things that really looked like, had words in them like guidelines and guidance. This picture here is their diagnostic algorithm. If you look at that in detail, it's pretty much the same as anything that we'd use now. It's just all moved on from there. And they made some fairly reasonable recommendations against the evidence of the time: painkillers, muscle relaxants, use opioids. This is they were keen on opioids, manual therapy, all of these things. But they were against all sorts of invasive procedures. They were against acupuncture. They were against bed rest, and they were against specific exercise programs. And I read this, and I thought this all seems fairly reasonable. This is something, because by this time I'm interested in back pain academically, and it seems all fairly reasonable to me. But this wasn't well received in the States. Didn't go down well at all. There were massive lobbying against the Agency for Healthcare Policy and Research and their guideline development, driven by the Spinal Surgeons Committee. This got to the stage, of course, being the States, somebody tried to sue them for malpractice and stop them disseminating guidelines, and they managed to lobby enough members of Congress to get the funding turned off for AHCPR and temporarily, and to stop them doing any more guidelines. So they stopped the production of new guidelines in the United States. This is getting ugly. This is not nice, because people are doing this, they're doing stuff in good faith, and it gets unpleasant. The first thing that looks remotely like guidelines in the UK is the Clinical Standards Advisory Group, also 1994. Again, final outcome measure, maintain productive activity and reduce work loss. Nothing here about making people feel better or improving back pain disability. It's all about people being at work. And they came up with very similar stuff, although they did say practice psychosocial management, and this is fundamental. So this is the first time that the psychosocial aspect is coming into play. But again, it's about acute back pain, and it's, if things go on for more than a few days, start treating things. They're against narcotics when not much previously the AHCPR had been for them, and stay at work. So this is the first bit of stuff that we're looking at that might change the way we work and trying to improve patient outcomes that you can really apply in the UK. Here's the evaluation that we did of this, looking at services and how it changed services. And the bottom line is the Clinical Standards Advisory Group saying to improve services. GPs we surveyed could see no difference whatsoever in the quality, in what they had available. Next off the blocks, this is the these are the RCGP acute low back pain guidelines, and this is a photograph of a rare first edition. Now, the big leap forward with the a couple of big leaps forward with the RCGP guidance is, first of all, they've got a manual for the first time, rather than a set of guidelines being a lot of people saying, well, this is what we thought we would do, and this is the guidance. They've laid something down a priori that says, this is what we're going to do, and this is what we're going to do it, following a set of guidelines. And that's the sort of thing that gives you a robust process. Like any trial, if you're doing any piece of research, you write down your protocol first, and you know what you're doing. And that's the sort of thing that gives you confidence in them. Another interesting thing here is that, well, the laser worked when I tried it yesterday. Anyway, the other interesting thing here is the people they brought into it. They brought in the chiropractors, the osteopaths, the physiotherapists, and the National Back Pain Association. Patient input into this right back in 1995. They looked at all the basic same evidence. Most of this you wouldn't be too controversial these days. Maybe unusual that we would talk, they would recommend diazepam. Very keen on staying active and returning to work. Poor manual therapy. A cynic might wonder how likely it was they were not going to recommend manipulation when the osteopaths and chiropractors were introduced into the group. And they were for favor of an exercise program. But interestingly, they were focused on acute back pain. And they realized at this point that maybe that isn't the time to do exercise, and maybe it should be by 6 weeks if people are not getting better. But they had no evidence for that. They had to just say it was theoretical. They had nothing to support that. And they were against opioids, they were against bed rest. So, question here is, what was the impact of the RCGP guidelines. This is a review, this is a trial people did of implementing these. And the bottom line is it made no difference to GPs' adherence to guidelines. Training GPs didn't change anything whatsoever that they did. Next in the history line are the European guidelines, COST B19 back pain guidelines, 2006. Now, there is a cautionary tale for you here. If you're producing guidance and you're putting it on the internet for people as a resource for people to use, you must take great care in how you curate and look after your URL. Because if you go to the URL for the COST B19 guidelines, this is what you get. So this isn't going to help you to manage your back pain or help your back pain patients. Now, they're in the kitchen sink mode. They're going to throw everything at this. But they do on first time, Tamal Pincus will be pleased to know, this is the first time that somebody says you should reassure your patients. But again, stay active, painkillers. They talk about muscle relaxants. Muscle relaxants come up quite often in guidelines. And just to be clear, in the UK, when we talk about muscle relaxants, we usually mean diazepam. In the rest of the world, they mean a whole range of different drugs, most of which are not marketed in this country. And they're, again, the first time we're coming into multidisciplinary rehabilitation. And these have got a Europe-wide focus. And that's for acute back pain. For chronic back pain, they throw even more of the kitchen sink at it. Everything's there. NSAIDs, antidepressants, muscle relaxants, pens, neuroreflexotherapy. For those of you who don't know, neuroreflexotherapy is essentially sticking staples in your ear. And they're into back schools, short-term NSAIDs. But they're not keen on surgery. Surgery for non-specific chronic low back pain cannot be recommended unless 2 years of all other treatments have failed. I cannot imagine how they thought anybody was going to get through all of those treatments in anything under about 5 years. And I would also draw your attention here to capiscum plasters. I'll come back to those later, but just to note that they get a mention here. And they're against almost everything that involves sticking something into you, apart from neuroreflexotherapy. They're against acupuncture, they're against radio frequency, they're against facet joint injections, they're against prolotherapy. So, again, broadly okay for the time. To my mind, nothing too contentious there. Now, we now come on to where I get involved, which is the NICE back pain guidelines. And if it says NICE on the can, you know you can trust what's inside it. And you really can. This is the current NICE Technology Evaluations Manual. It's the manual that NICE works to. It's got the last updated in 2023. And it is, it's 200 pages long, if anybody wishes to read that. And these were the NICE back pain guidelines that came out in 2009. And I was the chair of the guideline development group. And some of the people who are present were also part of this development group. It's interesting getting appointed to the chair here. There wasn't an interview process. There was a process, but essentially I got the tap on the shoulder and said, we're doing some guidelines for primary care. We suggest you should apply. And I'm not sure that there were any other applicants. And it was a very informal interview process. But I was appointed through a process, and we appointed the committee against criteria about the groups that NICE had suggested that should be there. And we had a scope, and it's one of the things about NICE guidance, has a very detailed scope with many stakeholders contributing to it to say what it is what we're going to look at, and specifying the questions that we want to see. Because clearly, you have to almost set your research question, but it's what's the question that we want answered about what thing we want to be able to comment upon. And you can't comment on anything until you've made unless you've done the review to provide the literature. So this is our brief, and this is important for understanding this when you come to talking about what happened next. Is our brief was for back pain between 6 weeks and 12 months, which doesn't fit into any of the criteria that we use for defining back pain. And the original scope stage, it was 6 weeks to 6 months, but it was changed to 12 months on the grounds that there would have been no research specific to subacute back pain and back pain for up to 6 months. And by extending it to 12 months, we could use some of the chronic back pain literature. And it doesn't address the management of severe disabling low back pain for over 12 months. And it's got a primary care focus because it's the early management. And these are the things that we recommended: activity, manual therapy, acupuncture. So here's first time acupuncture is coming in as with a positive recommendation. Cautious recommendation for opioids. We were favour of antidepressants. And we were asked the question of when should people be referred for consideration of surgery? And that's a difficult one because I don't think you find any research to define referral criteria for surgery. But we did manage to find some very limited evidence to suggest there might be some benefit from spinal fusion in some people. So we said, if other treatments haven't worked, you could consider referral for surgical opinion. But we couldn't say what surgery people might have because that's not in our brief, and we didn't look at the research for that. And we recommended against all sorts of things, including most invasive procedures. We're particularly against facet joint injections and against radiofrequency. Again, not universally welcomed. Again, these are some of the comments that came on the rapid response on BMJ website for this. Our patients deserve more. You're given an opportunity of a diagnosis and treatment rather than just acupuncture and manipulation. Aren't acupuncture and manipulation treatments? Anyway, here it gets a little bit personal for me. Professor Underwood is an honourable man. That's pretty bad. The coordinator of the BEAM trial of exercise and manual therapy. Now, if this commentator had read the processes carefully, they will see that we all stepped out of the room for decisions about the things we had an interest in. So I was not in the room, and neither was Steve, when the decision about manual therapy was made. Although we weren't able to do that for the exercise recommendation, because if everyone who believed in exercise stepped out of the room for the decision, there'd be nobody left in the room to make a decision. And again, the same commentator, a biased group with pre-existing strong beliefs. So here we are being personally criticised. And I got a reasonable amount of personal criticism here. What would now, I think, be called internet trolling, but social media didn't exist in those days. But about my view on this, particularly about acupuncture and why we were prepared to recommend that. But then it got ugly again. The interventional pain community were really unhappy about our recommendations, felt they hadn't been properly represented. They managed to oust Paul Watson, who was the clinical advisor on this group, was ousted as the president-elect of the Pain Society. The whole guidance was suggested it should be withdrawn, and it was seen as an existential threat to services for back pain. And this was nearly destroyed the Pain Society, the fallout from all of this, which is completely unintended. Because if you look here at what we did for our research recommendations, we were really careful to make it clear that we needed more research on facet joint injections and radio frequency, and that these weren't things that would happen in 12 months. So why should saying that people shouldn't have these treatments within 12 months affect services in pain clinics, where most people can't get into a pain clinic in anything under 2 years? I didn't get this. I couldn't see why this was a problem and why people should see this as a threat to pain clinic services. So, what was the impact of this? Lovely pie in the sky. I like that. Basically, the feedback on evaluation that people did on the 209 guidance is it had really no difference on what went on in the consulting room. Effect on pain services. I couldn't find any references to evidence this, but actually the fears of the pain community were fully justified. There were huge threats to pain services, and I think they have now recovered from this, are completely unnecessary. And the other main impact of this was the guidelines being withdrawn and new guidelines being developed for the back pain with a different brief for all pain, acute and chronic, and including sciatica. Massive brief. Don't know how they thought they were going to cope with it. And here's the new guideline development committee. And you remember the comment I made about honourable and scientific people. That was made by a pain physician, Chris Wells, who's in this committee. And of course, Stephen Ward, who's the chair of this committee, was also a pain physician and was also in private practice. And frankly, there's not much difference in the recommendations they make here. They're a bit more cautious, a little less supportive of things, wanting more combination therapies rather than individual therapies. But very little difference there, apart from the positive recommendation for radio frequency, which, in all honesty, they were given a slightly different set of data to look at. There's one more trial that we hadn't had available, and they've got a different brief. We may well have made the same recommendation with the brief and scope, data and scope that they had. But they came down against acupuncture, and the reason for this is this time the committee wanted to look at studies with sham or placebo controls rather than looking at usual care controls. Once you make that decision, you're going to end up making different conclusions. And so, impact of NICE 2016 guidelines, I couldn't find any papers assessing this. I think that I take this to mean people are getting bored with back pain guidelines and don't want to know whether they work or not because they don't think they do very much. But I have spent some time thinking about NICE guidance. Actually, I like NICE guidance. You can get right under the hood, you can play, you can see the mechanisms of what's going on, and there are robust systems in place to keep it up to date. There'll still be NICE back pain guidance, as far as we can judge, going forward for the next umpteen years. So it brings me to the most recent set of guidance, which is the WHO guidance. And this is for chronic primary low back pain in adults in primary care and community settings, and it's got a global perspective. So notice here the difference. Here, this was very much the tap on the shoulder. Would I like to be the co-chair of this group? Again, a difference with WHO. This is their WHO guideline development group. As far as I can see, this hasn't been updated since 2012. So it's not up to date. It's nothing like as detailed as in the NICE guidance. And instead of NICE, where we had a monthly trip down to London to speak all day to talk about things, this is all done in online sessions across different time zones of 2 hours at a time. And importantly, the meetings were chaired on the whole by an independent methodologist rather than either of the two co-chairs. And the whole world and his brother, oh, it is WHO, but it is the whole world and his brother were on this. 25 members, 12 from low-income countries, a co-chair from Pakistan, a steering group of 20 people, external review groups, international stakeholder groups observing the meetings. They're all over it. Massive piece of work. 8 review teams globally, over 100 members. But interestingly, the reviews were not part of the final guideline document. So if you really wanted to get under the bonnet and see the workings of WHO guidelines, you can't. The reviews are being gradually published as individual papers, but trying to make the link from the WHO guidelines to the reviews is really hard. And this is what we came up for being positive. We're for education, we're for exercise, we're for needling therapies, which is both neuroreflexotherapy and acupuncture. We're for NSAIDs. Topical KN, pepper got in. Think back Capiscum plasters from 2019. And this is the same sort of stuff you're using capsaicin for knee OA. We're against all of these sorts of things because there was evidence showing they didn't work. There was here's a gang of things, so there's no evidence that we made no recommendations. But we got ourselves into a problem with some treatments for which there was no evidence, so we can't make a recommendation for or against because we can't say whether or not it works. But we didn't actually think people should use it. So this was a bit tricky. So we've made statements to say there isn't enough evidence to make a decision, but we are concerned about this. Benzodiazepines and cannabis for obvious reasons. Paracetamol because the evidence is not there for acute back pain that it works, so why should we think it works for chronic back pain when there's no other evidence for it? So the overall message from these guidelines, basically they're all pretty much the same. Some difference at the margins due to scope, method, who's in the guidelines, emerging evidence, opioids, paracetamol. They're all pretty much the same. So what's good? What's a good guideline? This is very hard. Here's a quote from the foreword of Principia Ethica, an important book in philosophy on trying to understand what is good. And what he says in the foreword is, it's like trying to explain to somebody what the colour yellow is when to somebody who's been blind since birth. You can't do it. There are formal criteria, Agree To criteria or Institute of Medicine criteria. You could try and use these as scoring, but if the guideline is flawed on one basic point, then it isn't going to be, you can't trust it. So you just have to look at it and get a feel for what you think is good. So for me, I think nice guidance is good. It's comprehensive, there's detailed manual, rigorous reporting, and periodic update and maintenance. I like WHO, it's current, it's got a global perspective, but the reporting of the development process is opaque. And if I hadn't have been in there absolutely on every little bit of detail of this, I'm not sure as an external observer I would be so sure it is good, but it is good. What's bad? Here's a bit of an email I got recently about an area of some interest to me, about somebody wanting me to join a new guideline development group because they're doing a network meta-analysis of treatments for this. So they don't yet know if there's any new evidence to change existing guidelines. And they've already assessed the existing guidelines in the area and decided one of them meets their criteria for being good guidance. So they've got no new evidence and there's a good guideline that already exists. So I said to them, can I have your scope and your process manual? And they don't have them. So they don't know what they're starting from. So I have no idea whether you're going to be able to trust what comes out of this. And it's an unfunded project led by a postdoc. When, go back to 1979, we had Archie Cochrane leading it. The world has gone down. What is ugly? Personal attacks on GDG members. That's unacceptable. GDG members who don't stick to what was on the pattern. We're all there, we all agreed it. Whether you liked it or not on the day, when you're talking publicly, you have to like it. Ugly is trying to subvert the guideline process. A lot of this goes on. I've seen this in a guideline produced by a professional society, where one of the sponsors of the professional society tried to lobby people to change the guidance. The professional society refused to do that. They lost some sponsorship and they stopped paying the travel expenses for the people who were doing the work on the guidelines. Also, the guidelines shouldn't be a threat to professional identity. We all have our professional identity. It's the skill weeks we come through. If you remove our professional identity, there's a real risk that you'll lose the active ingredient, the thing that makes it successful at what we do. And here's some qualitative work on this. Quiet dissent. They're seen to threaten professional identity, and the only change management as pragmatic response to healthcare market forces is clinical practice modified. And this is actually a study of osteopaths, but you could look at this lens for any one of you in your professional identity. That actually the problem here is the expert opinion and the way you're trained still overshadows the guidance stuff. So how you square the circle of implementing the guidance and changing and following good guideline practice and maintaining your expert opinion and your professional identity is quite a challenge going forward. So if we come back to my mother, if she had her back pain now, basically if you were to synthesize all of these guidance, above the line is acute back pain, and basically advice not to rest, information, reassurance, education, NSAIDs for some, and at least in some guidelines, topical cayenne pepper. Below the line, structured exercise for more chronic pain, structured exercise, go to work, combined physical and psychological approaches, and then depending on which guideline you like and who you believe, manual therapy, behavioral approaches, acupuncture, radiofrequency. And that, if I was back as an early career GP now, I could see that as a sort of structured program that I could live with. It would help me in my work. And this is all really very, very useful. However, I'm thinking of that as a great deal of progress. But there are two big elephants in the room. And the first elephant is we've had 30 odd years of Cochrane reviews, evidence-based medicine, evidence synthesis, meta-analysis, many thousands of days of researcher time, pulling all the evidence together, looking at the randomized controlled trials, developing really good processes for guideline development, massive work put into it, and all of this stuff. But actually, if you look at the underpinning evidence, most of it is rubbish. It's small quality, poorly done trials. You're struggling to get really good evidence to actually underpin this. And it doesn't matter how clever you are with your guideline process manuals and your 200 pages from NICE, this isn't going to help you. And by way of example, this is a piece of work it's in press with BMJ Open at the moment. This is just one slide from it. And this is looking reanalysis of the data from Cochrane Review from 2021 of chronic back pain. And this is the mean difference in outcome for pain at the first follow-up in all the trials in that review. And if you separate this out into trials with fewer than 70 participants, you get a mean effect size of about 17 points on a 100-point scale, clearly significant, very important, well worth it. But those are all the unfunded projects, the student projects, the apprentice pieces, the things that people are trying out to do stuff. But if you look at the larger trials, more than 70 people, which are predominantly the larger professionally done studies, these are, the mean effect size here is about 8 points on a 100-point scale. And the authors of the Cochrane Review set the mean difference of being clinically important as 15 points. So this is clearly highly statistically significant, but with an effect size which, by the metrics used by the authors of the Cochrane Review, is clinically irrelevant. And this is for the one thing we all really believe in. And there's, I think it was 170 odd studies in that review. The one that's coming, when it's updated, there's 426 of them. Why on earth are we still doing trials on this stuff? The evidence here is that it doesn't have a clinically useful effect. So important to realize the evidence underpinning all of this is very weak. And then there is the second elephant in the room, which is what impact has all of this had? We've done a lot of work. I've committed a lot of my professional life to guidelines and to back pain guidelines in different ways. And these are data from the Global Burden of Disease. If you're interested in this stuff, you can look it up. This is the years lived with disability, which is their equivalent of QALY impact, corrected for population breakdown. And this is the data for England, because that is where NICE applies. And you can see with all these various guidelines that I've talked to you about over time, there is no indication here that there's any clear causal effect between these guidelines and a reduction in level of back pain disability. You will, however, see that at the end of the line here, in 2020, there is a reduction. And of course, this is when COVID hit. So maybe, I mean, there may be that there's an effect here, a functional effect on how COVID affected the measurement of disability in that time. But of course, the other possibility is actually when we all sat at home doing nothing, not doing any exercise and not going to work, that was the thing that reduced the impact of back pain. So it's a lot of work, a lot of good stuff, a nice framework that helps us to work clinically. But what impact it is having, I'm not sure it's having the impact we would have had. And maybe we need to think about other ways about how we're going to reduce the population burden of back pain. Thank you.
Thank you very much, Martin. We're happy we've got a little bit of time. I know after this we've got AGMs to rush to for different societies, but we've got a little bit of time for some questions.
Stephen up here.
Can't see
Here?
where, but
Yes, it's here.
fantastic. Okay.
Rajat Verma, I'm a spine surgeon. I work in Manchester. Looking at your slides, you clearly started off with the premise that the guidelines should apply to acute, non-specific back pain. It was highlighted. And to me, that means you don't know why the back pain is happening. You don't know whether there's a facet arthritis, whether there's a slip disc or whatever it is. You don't know why it's happening. Or you've done the imaging and you find there's nothing going on. So I have no problems not injecting, and the injectors and the surgeon should not be offended if it is not recommended by the guideline. But I've seen that that word of non-specific has been dropped. Was that an intentional dropping of the word, or was that just morphed into something just covers back pain as a whole?
Yeah. No, it has, I mean, different guidelines have defined things in different ways. And one of the things you'll have noted, and maybe not, I haven't emphasized it quite enough, is the change from it being we're interested in acute back pain to we're interested in back pain from 6 weeks to a year, to guidelines being all, the second lot of NICE guidance, it was all duration of back pain. WHO, it was specifically chronic back pain. Now, I haven't talked about what the guidelines say about diagnosis and separating things out into non-specific back pain, but actually they're all talking about non-specific back pain, whatever it is you would like to interpret as being non-specific.
But you see, that creates that vacuum where people, it is open to interpretations. Those service managers will interpret it in a different way to a clinician who's treating patients and the patient who's being, I'm a surgeon. I also have back pain. I also had a problem with back. So I'm coming from the point of view of the patient as well. So it leaves it so widely open to interpretation that it becomes not very useful. Thank you.
Thank you.
Next question, thank you.
David Wong from Denver, Colorado in the US. I'm actually the past president of NASS and the past chair of the Academy of Orthopedic Surgeons Guidelines Committee and the NASS Guidelines Committee. Enjoyed your talk a lot. That was one of the big reasons I came over, and despite the fact that they turned down my abstract. But I think a point that needs to be made is keep politics out of it. That's what happened with the HCPR guidelines. Because we had no problem with the guidelines. Acute meant 30 days, and back problems included both back pain and sciatica. And nobody had any umbrage that there was a problem not having a lot of surgery in the first 30 days.
Yeah.
But when that was presented to the public and in the press conference, they said, this means there's no good place for surgery in back pain or sciatica. That's what everybody got upset about. They did not get upset about the guideline.
Yeah.
And that's where this whole thing came, because that's the nice thing about the NICE guidelines and stuff. Keep the politics out of it, because then in the US, they tried to use that guideline to reduce the funding for back surgeries and things like that. That's where the politics got into it.
Yeah, and you're right. Exactly the same thing happened with the first set of NICE guidance. You know, it's guidance up to a year. The pain community, it was used to something to beat the pain community up, and it really did cause problems. And they were right that this was a threat. But we as NICE, doing the NICE guidance, didn't see this as a threat because we were only doing it up to a year. And so, you know, it is really hard because people don't read it carefully, and it applies to what it applies to. So again, if you look at the WHO guidance, it is very much, it is the primary care aspect of it. We don't say anything there about what role, where surgery fits into it. There we don't talk about sciatica. We only talk about back pain. You know, be clear what you're talking about, what the guidance is doing.
Yeah. Thank you.
I can't see any more questions in the room, which is fine because we're just a few minutes over. So I'd ask the audience to give Martin one more round of applause.